Morning and welcome to this lipid panel. My name is Dr. Merle Meyerson. I'm co-chair of the programming for the lipid panel, working alongside Dr. Guy Mintz and NLA liaison Chris DeVille. The lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, lipid clinic conference is a great way to debrief after busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, and come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you are not alone. If you have cases you want to be presented at future conferences, please email us with your suggestions. So in this series, as you know, we will review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we will try to cover as many important clinical topics every lipid specialist should know. So tonight we're joined by a stellar cast. We're focusing on pediatric patients tonight. We have Lisa Hudgins. Dr. Hudgins is an associate professor of pediatrics at Weill Cornell Medical College and pediatric director of the Rogosin Institute Comprehensive Lipid Control Center for over 30 years. Prior to that, after completing medical school at the University of Pennsylvania and her pediatric residency at Jacobi and Einstein hospitals, she spent 15 years in patient-oriented lipid research at the Rockefeller University. Maya Rashad is a registered dietitian at Cook's Children's Medical Center in Fort Worth, Texas. She currently works at the REACH Clinic, a pediatric lipid clinic, where she provides nutrition care and counseling to patients diagnosed with lipid disorders. She obtained her bachelor's degree in nutrition at Howard University and currently finishing her Master of Public Health with a concentration in epidemiology at University of Memphis. And she was one of the NLA's lipid scholars during the spring of 2024. Dr. Amy Shah is a pediatric endocrinologist, clinical lipidologist, and professor of pediatrics at Cincinnati Children's Hospital Medical Center. Her research and clinical work focus on youth-onset type 2 diabetes, risk factors including impact of lipids, complications, and best treatments. She also sees patients in the preventive cardiology clinic. Don Wilson is known to many of us. He's a pediatric endocrinologist focused on cardiovascular health and risk prevention in children and adolescents. He is the endowed chair of pediatric cardiovascular health and risk prevention program at Cook Children's Medical Center in Fort Worth, Texas. He's also an associate editor for the Journal of Clinical Lipidology and an author and reviewer in many publications over the years. He's held many leadership positions within the National Lipid Association. Thank you all for joining us. I'm going to turn this over to our case presenter, Maya Rashad. Maya?
Thank you so much, Dr. Meyerson, for that introduction, and thank you again for inviting me tonight to present this case. This evening, we will be going over a metabolic syndrome patient for a kiddo that we saw at our pediatric lipid clinic. As we all know, there has been an unprecedented rise of overweight and obesity in our pediatric population, so we're starting to see a lot of kids with an increased prevalence of these cardiometabolic risk factors. So for our case today, we will be following a 14-year-old female who's referred to our clinic for dyslipidemia and insulin resistance. At the time of her referral, the patient was actually asymptomatic, but the dyslipidemia and insulin resistance was discovered during routine labs ordered by her pediatrician. The patient had a past medical history of hypertension. However, she was not on any medications for it at this time. She also reported not having normal menstrual cycles, and she first underwent menses at age 10, and she only has typically about 1 to 2 cycles in a year. She does have a history of migraines without aura, and then she does have a history of anxiety. And so on this next slide, we see the patient's growth chart. And for you guys who are not in pediatrics, you may not be familiar with this. but this is a visual tool that is published by the CDC and WHO that provides a way to track your child's growth and development. And so looking at the chart, we normally have the kid's age on the x-axis, and you normally find their BMI on the y-axis. And the point where the two axes meet is where you plot it. And you can see for this kiddo, she was a normal weight for her age, and her BMI was in a healthy age as of 10, but she did have a significant increase in weight, which placed her BMI in that severe obese range. And what's interesting about this chart is that this is an extended BMI, and because we're having so many kids nowadays that have these higher than normal BMIs, the CDC published a new chart that concluded percentiles higher than the typical, which used to be the 95th. And that significant weight gain also correlates to the onset of that menses that we saw in the previous slide.
So I'd just like to stop right there, Maya, if you don't mind going back and just ask our panel and our experts here, when you see this kind of growth chart, what does it make you think? What are you concerned about? What are the things that stick out to you the most? I'd ask either Dr. Wilson or Dr. Hudgins to maybe comment on that.
Well, the first thing that I would check would be the length changes also, because we want to be sure that this is not some other metabolic process that would lead to delayed impaired growth coupled with obesity, like hypothyroidism or Cushing's. And so what was her change in height?
So she did follow her growth curve for her height. She always has been kind of in that 90th to 95th percentile, and that stayed consistent.
Okay.
A couple of comments, Amy. One is this is a very common scenario. I think most of the people who do pediatrics see this quite frequently. Number two, you see the sustained elevation of her BMI. So whatever's going on has been present for a long time. And so one of the questions we'll ask at some point, is that concerning to you? And if so, what have you tried in the past, or what's been successful, what's not been successful, and perhaps why? But I'm not so much worried about the elevation of the absolute number. I mean, anything over the 95th percentile is considered obese. Anything over the 99th percentile is considered morbid obesity. Those are just terms of gradations. I think what we all know is that there's a continuum of risk here. So starting at the 85th percentile, which is defined as overweight, then you start worrying about the trajectory of that weight and what it's going to do in terms of metabolic function.
It is a good I think it's unusual to see a plateauing and even a little bit of a decrease. Yeah. Usually you see it just skyrocketing continuously up. And so there's something that's going on that's right here, but it could certainly be improved.
Exactly. And the other thing is that I'm sure Lisa probably says the same thing. The kids that we're seeing more and more of are the kids who are morbidly obese, not just obese, but morbidly so. So it's very difficult to come back from a BMI of 99th percentile.
Most definitely. And so in terms of some other background on the patient, the only pre-visit medication she was on was Topamax, which was prescribed by her neurologist for her migraines. There is a very strong history of cardiovascular disease and other metabolic disorders on both the mom and the dad side of the family. And also both of the parents have undergone some form of bariatric surgery in the past. And then there's a lot of type 2 diabetes on both sides. And in terms of the patient's social history, she's an only child. She lives at home with mom and dad. Both of them have college degrees, and she isn't involved in any after-school sports or activities.
Now, one thing I was going to say is I did notice that her weight had been previously in a more normal range. And so that begs also two other questions sometimes we think about. One was she on any medication previously that could have contributed to weight gain? So a lot of Pediatric patients will see what this kind of weight gain might have been on atypical antipsychotics. It doesn't look to be the case here. And then sometimes if there's something that happened in her childhood or in her life that could have changed, you know, sometimes just stressors alone can trigger a different trajectory for some patients. But it sounds like maybe those things weren't happening with this child. But just to kind of go back to those 2 points.
The antipsychotic point that you made is that often that history is hidden.
Yes.
I sort of have to really push and specifically ask about it, and
Yeah.
even then, it's not revealed.
So, Amy, if I might, I wonder if you or Lisa could comment. You know, we're seeing more and more parents, either one or both, with this bariatric surgery. Now that may change going forward because of the new meds, but you know, it's been startling to me. If you don't ask that question, let's say you have the mother in the room, if you don't ask the question, has anybody had any kind of weight-related issues or had any kind of surgery? You might be startled to find out that that woman sitting in front of you was 350 pounds and had some type of gastric procedure. And all of a sudden she looks like she's melted down to nothing. But it does make a difference in terms of the conversation, at least in my experience.
I always ask the parent for the parental history, what was the maximum weight? And then what is the current weight? And then of course, what's the height? And that's the way you can really discover that who looks like a normal weight person was actually huge.
I like your approach. The other important thing is here, we can all learn a lot by listening to what the parents' history is that had the bariatric surgery and why they made that decision. You know, were they having problems prior to? Because it's going to help understand kind of where they want to go with their child or where their child's decisions may be.
Yes.
It's been very informative.
And whether they've received any of these newer drugs and so
Yeah,
forth.
exactly right.
Exactly. And then going back to the first point you mentioned, Dr. Shah, I did not see any known history of her using any antipsychotic, but she was in some form of clinical therapy due to like emotional eating around that 10 years of age.
Okay.
And then here is the patient's vitals and the physical exam that was conducted at that first visit. And we've already talked about how her BMI met the criteria for not only obesity, but for that stage 2 obesity, just given where she fell into the percentile of the 95th. Her blood pressure was also elevated, which we, suspected given her history of hypertension. But her heart rate was normal. And then in terms of her physical findings, the patient did have that visceral adiposity we normally see with insulin resistance. Facial hair, the patient did report shaving every 2 days, and she had, hair also similar with male pattern growth. And then there was that acanthosis that was noted on her neck and elbow.
And Maya, let me just ask you, we often find this, that if a blood pressure is taken, as somebody's kind of runs into the clinic because they were running late for their clinic appointment, you can get numbers like this. Do you have any details on if the blood pressure was, repeated? Was it a manual blood pressure? Maybe our panelists kind of want to take a stab at, measuring blood pressure in pediatric patients and some of the things that can cause you to get really high numbers like this, which could be true, but sometimes not.
So I know from looking at her EMR, the patient did have a history of that elevated diastolic and systolic blood pressure even at home. And the blood pressure was repeated using a manual one, and it still was elevated.
Of course, the big problem is finding a cuff that's appropriate, a cuff size. If it's too small, you'll get artificially high values. But why did she have the diagnosis of hypertension? Just based on home measurements? Or I'm just curious, how much hypertension for how long?
There was previous documented hypertension with the pediatrician well visits, but she was never referred at that time for further treatment or evaluation.
Okay.
And then here are those referral labs that were done that ultimately got her seen at our clinic. For her lipid panel, she did have that moderately elevated triglycerides and the elevated non-HDL cholesterol, which we oftentimes see with our kiddos that have, an obese BMI and that visceral adiposity. Her A1C was elevated at 6.3, very close to kind of that range where we started thinking about, is this pre-diabetes or is this diabetes? Her liver enzymes were elevated, as well as her fasting blood sugar. But her thyroid and her renal labs were found to be normal.
Do we want to expand a little bit on the use of non-HDL in this setting?
Well, I think most people know that lipid panel that you see there looks pretty typical. So you're going to have those modestly elevated triglycerides, 250, 350. HDL is going to be low, and then the LDL cholesterol level actually looks pretty normal, maybe mildly elevated, but not usually like in the FH range. And so then, at least for our practice, I suspect the rest of you kind of focus on the non-HDL, which is kind of giving you a summation of some of the atherogenic lipoproteins that are floating around here. But this is very typical. And then when you see the lipid profile, the insulin resistance profile, A1C elevated and fasting glucose, as Maya said, we tend to do a lot of glucose tolerance tests in these kids because to me, the gold standard really is glucose tolerance test if it's performed correctly. And the A1C is not necessarily recognized by the ADA for diagnosis of children, but it's a good indicator. So I think at the end of the day, we're looking for where is this kid in this metabolic process, and then what are our therapeutic options?
And this is a hefty triglyceride level. And, it's not the 500 plus when we start getting concerned about acute pancreatitis, but she could easily, with rapid weight gain, push it into that realm. So that really has to be watched with more frequent visits or at least blood sampling, lipid sampling, to be sure she's not wandering into that range where it's really a life-threatening event. And the other thing is that, of course, the LDL, even though it's normal, likely represents small, dense LDL that are more atherogenic than usual LDL.
So just continuing on with her assessment, whenever we have a new patient or a follow-up patient at our clinic, I always do a diary call to assess kind of the patient's baseline eating habits and how they've changed and improved. For this patient, I won't give you the nitty-gritty details of exactly what she's eating every day, but just the patterns that I was able to see from their diary call. And so this is a patient that we see has a moderate to high intake of processed foods. So when I say processed foods, I mean our high sodium, high fat, ramen noodles, frozen dinners. She had very little fruit or vegetable intake or any sort of fiber-rich foods. Daily consumption of calorically sweetened beverages. For those of you at home, that would be things like juice, soda. She was eating large portion sizes beginning at age 9 or 10 years of age per mom. She started eating the same size portion that the adults were in the house, if not more. And many of their meals are consumed away from the house and not eaten in a family style. And then post her initial lab draw, the mom initially tried a keto diet for the patient to see if that could improve her dyslipidemia. Which we both know that keto diet, if anything, probably will cause dyslipidemia if you didn't already have it. And it's not any recommended treatment in terms of dietary intervention for high cholesterol or high lipids. And then for her physical activity, patient was sedentary, little to no physical activity besides her daily activities. And so just given the patient's biochemical, physical, and family history, we see that we have a kid with an obese BMI, hypertension, strong family history, as well as that moderately elevated triglycerides. What for the panel do you believe are this patient's active cardiometabolic issues? And then what are her unifying diagnoses? And given your answer to number one, what do you believe would be your next steps for this patient?
Before the panel goes to answer that, because I'm sure everybody would love to hear, what we might do is just poll the audience. Because what we've heard is that this patient has a number of things going on. Maya, just as you said, we heard irregular periods and hirsutism, prediabetes, dyslipidemia, hypertension, and really, we would like to know from the audience this question here: what of the current problems do you think is the most critical to tackle at this visit? If you had to pick one, and there might not be a right answer, but we'd love to hear. Okay, so I'll take this to our panelists to get your thoughts on maybe how you might have answered this question, and what and your thoughts, based on what the audience has said. And this is not there might not be one right answer kind of question.
Well, it's very interesting. This is a lipid panel discussion, but nobody chose dyslipidemia, right? Well, I think this child, well, first of all, you may know that there's no generally agreed on definition of metabolic syndrome in pediatrics. I suspect that there's a lot of discussion in the adult world, and there are a variety of reasons for that. First of all, the measurements, if you do waist circumference or those kind of things, are very difficult and not standardized necessarily. So, I think most of us have a gestalt for a child who has significant weight gain, accelerated weight gain, persistent obesity or morbid obesity. And then you add to it in girls the irregular menses, the elevated blood pressure, the dyslipidemia that we talked about, and the hypertension. You sort of get this composite picture of what we would call metabolic syndrome. Perhaps worse than that, if you start looking at the ICD coding, most of those codes are all the same thing. So if you say accelerated weight gain, it implies insulin resistance and so forth and so on. So there's some technical issues we need to work out when we're studying or trying to understand the best outcomes for these kids. But, my simple answer to this is the answer is all the above. At some point you need to deal with that. And so I like the idea of creating a problem list. But these are difficult patients because they have so many issues that you could tackle. And at least my mistake in the past is trying to do too much too quick. So then you have to sort of ask the question, well, what's the underlying theme in metabolic syndrome? And so many people would say, well, it's really a combination of weight gain, which kind of gets the ball rolling, insulin resistance and inflammation. And then all these other things sort of occur as a consequence of that. Now, it's much more complicated than I just said. But I think what I would probably do is try to get to know this kid. And it's not always easy to know them and their family, but you have to take the time to sort of understand what their healthcare beliefs are, what they've done in the past, what this child's interest is in attacking any of these problems. So that takes a lot of rapport. So you want to know a little bit about her personal interests, how she's doing in school. One of the things that we didn't touch on here is sleep health. We don't know how she's doing in terms of that anxiety and sleeping. That could be another part of this, as pointed out about like the American Heart Association. But at the end of the day, I would probably guess that a lot of young teenage girls like this are most concerned about the irregular menses. And the reason for that is that she's, as Maya said, she's actually shaving a couple of times a day, or a couple of times a week, sorry. And she's having irregular menses, so she doesn't know when her period's coming on. Now that may not be my top priority, but that might be hers. And so I need to listen to that, because if she's saying irregular menses and I'm saying I'm scared to death you're going to develop diabetes or have it, then we're kind of cross purposes. If we start that,
I think hirsutism also has to be.
Yes.
Yeah.
Yeah, and those, as we all know, are difficult problems. We fortunately have a very good gynecologist that we talk with and have an understanding about how to approach these. But and some of you probably do this very well in your own clinics, but if you just think about the hirsutism, which is the most visible thing to a child this age, 16-year-old, well, that's got to be devastating at school in terms of her anxiety now being even worse as a consequence of being teased or identified in some way. But the point I was getting at is that, standard therapy would be to use some type of insulin sensitizer type thing like metformin, and then use some oral contraceptives or something to kind of regulate her cycles. But I think you have to be very explicit about the hair development, because what we know about the hair cycle, anything that you implement today, the child needs to know is not really going to be visible to you for 6 to 9 months. Otherwise, they're going to be upset that it didn't work in the first 2 weeks. They'll cast it out the window and not come back and see it. So whatever temporizing measure, we usually say, listen, if you're shaving, keep it up. You'll see that it diminishes over time. You want to use a cream, that's fine. Some girls will use like waxing and so forth and so on. So we want to try to navigate out of that. But the point being is what's really important to the child is their facial appearance and the perception by her peers. And then, we can start a conversation about what would you like to tackle first. For us, it would probably be her weight, but we wouldn't talk directly about her weight because that would be something that would be a little bit confrontational. I do ask, what's been your thought process in terms of what you've heard from other physicians or other healthcare professionals? And what's been disheartening is that a lot of times these kids have been, and the parents have been chastised. So they've been experienced, where it's kind of a victim mentality. You can do this. And if you don't do it, then it's your fault, kind of thing. So Lisa may have a better answer than I.
Well, I think that that the composition of the diet, that the especially for lipids, is so important, and so to shift the focus from cutting calories so much to really changing that carbohydrate balance, the type of carbohydrate, just so important. And it's so modifiable. And so again, getting back to really trying to understand what the barriers have been in adhering to a healthier diet and lifestyle. The physical activity is also important. And then so every single one of these things, except perhaps the irregular periods, are going to get better if she can lose weight. And so that brings up, of course, the discussion of these newer medicines, the GLP-1 receptor agonists, to introduce here, but only after a serious nutritional counseling, because I bet she hasn't even had that. Has she had any nutrition?
Yeah. Well, let's move on, Maya. Maybe you can fill us in on some of the things that you guys
Give us
did.
more detail there.
Yeah.
Yeah, so at this point, she did receive nutrition counseling that initial visit. Whether the patients want to receive it or not, they do receive some form of counseling. And
But had she had it before?
No, prior to this, no.
See?
Yeah, she had not had it prior. And then, like you said, especially for these patients, just getting them to lower their carbohydrate intake daily overall and the type of carbs. Honestly, I see drastic differences in the triglycerides almost kind of immediately after, especially for the kiddos who have that insulin resistance.
Yes, even without weight loss.
Yes.
Yes, exactly. Well, that's a good point, Lisa, because one of the things we like to do is, in the parents and kids to some degree, but the parents particularly, really kind of start focusing on the numbers. And so rather than having to talk about weight, which may or may not change between visits, you kind of reinforce the positivity of, hey, your numbers look much better.
Yeah, that's really our goal, are improving the metabolic consequences of the overweight.
Yeah.
But it's, you're in the long run, you're going to be better off having a lower weight for sure. And the likelihood is that you're going to continue to gain unless you have actively do something about it. Which brings me to the other question. They have been trying. What have they been trying? Because that weight curve looks like they've been trying something.
So the weight curve change that was seen after the visits. I pulled up her whole growth chart, so not just prior to us seeing her, but what it looked like as she started to be seen in our lipid clinic.
No, because you said 16, age 16. That was toward the end of that graph.
Right. So after like a couple visits with the team, that's when her weight started to curve off.
No,
Just going back to the first.
but there was still a plateau, yes, and then it did start to drop with your intervention. But yeah, go back to that. You see, so about 13 and well,
Right,
until
it's
about
16.
15.
Yeah, and
So-
she was saying 14 with us.
Yeah. Well, Maya, why don't we let you kind of progress so we can kind of hear how this
Yeah, let's go back to
played
you.
out a little bit. Maybe we'll get some of these answers. Perfect.
Yes, so here is the treatment plan that came up for the patient. So ultimately, the diagnoses that were given to the patient were for PCOS, given like the history, the irregular menses, the insulin resistance, prediabetes, obesity, hypertension, hypertriglyceridemia, as well as MASH, which we know now is the new acronym for the metabolic associated dysfunction for steatohepatitis. In terms of her meds, the patient was ordered to start a birth control of progesterone only and started on 1,000 milligrams of metformin twice a day. In terms of her referrals, she met with me, the dietitian, during the visit, and was also referred to nephrology given that persistent hypertension. And in terms of the diet prescription that I went over with the patient in the visit, she was taught about carb counting and choosing more high quality carbs and given a carb limit of about 60 grams per day for breakfast, lunch, and dinner. And she was recommended to achieve at least a 5 to 10% weight loss, which we know would help with the triglyceride elevation. And in terms of additional lab work, she was recommended to have an oral glucose tolerance test, a lipoprotein A, ApoB, a fasting lipid panel, and then a CMP. And she was ordered to come back to our clinic in about 3 months. And a little bit later on in the presentation, I'll give a more thorough explanation of kind of what the nutritional counseling looked like.
That's great. I was just going to stop there and just ask our panelists if they can comment on when you guys usually check LP little A's and ApoBs in pediatric patients.
When,
And
Go ahead. You want to go?
feel free, go ahead.
What did you say?
Go ahead.
go ahead, Dr.
Oh,
Hudgins, you're up.
Okay,
Yep.
so I never check ApoB. I always check LPA in everybody.
Yeah, so I would agree with the latter part. I mean, you know, when the world says all adults ought to have an LP checked at least once in their lifetime, I modify that to say all little adults, meaning kids. So one time I agree with that definition, right?
Yeah, it should be
But if
part
you're
of.
yeah, if you're looking for risk factors. So the other thing is that worries me because the reason she was put on a progestin only here is because of migraine headache history, which increases the risk of stroke. But if if she's on a high dose estrogen in particular, it increases the stroke risk. But if she has a high LP(a), it worries me. I don't have any data, but it worries me because that's also associated with stroke. So all that to say, I've kind of increasingly become fond of ApoB because the numbers actually, when you start doing anything to modify the cholesterol, particularly with lipid-lowering medications, I think the ApoB is actually a better post-treatment measure of atherogenic lipoproteins.
And remember, the cholesterol and LPA is measured in the cholesterol and LDL, the calculated LDL. And I've had LPA levels so high that it looks like heterozygous FH. So I need the LPA to interpret the LDL cholesterol level. That's one
Well,
reason.
Yeah, the other thing is you remember this family history now. It's a little complicated because they always throw in type 2 diabetes. So then when you see early MI and everything else, you're thinking, okay, well, maybe it's just diabetes. But who's not to say that the whole family doesn't have elevated Lp(a). And maybe there's a relative, either a child or a distant relative who has high Lp(a) that may not develop diabetes. So I think in terms of total risk assessment, it's been very helpful to look at that.
Okay, thanks. Go ahead, Maya.
The one thing we do with the glucose tolerance test is we find that most families, particularly our Hispanic population, relate to glucose numbers much better than they do to A1Cs, which is kind of a difficult concept for them in terms of percentages. The other thing we've seen is a lot of discordance between the glucose tolerance test and the A1C. And if we can get a number, either the A1C or the glucose tolerance test that's in the diabetes range, then we can actually get, in our state at least, things like Trulicity approved for these kids. So it gives us another therapeutic option.
Yeah. Okay, Maya, so show us what happened.
Yeah, so on this slide, we have the lab work for not only the first visit, post follow-up, but also for the second and third one, to really just show you that kind of pattern and trend of the different lab values. And so you can see here, comparing the baseline to her 3-month, there was a significant decrease in the triglyceride levels, as well as her A1C. And again, the patient was started on the metformin post-visit. She did complete the oral glucose tolerance test first, which did come back abnormal, not for diabetes, but just impaired glucose tolerance. And then once she was on the A1C, once she was on the metformin, her A1C came back all the way down to 5.6. So it was a significant decrease. Her BMI and her weight also improved. Her liver enzymes did as well.
And the lipids?
And the lipids, which we always love to see. And I know you had a discussion about the lipoprotein A. Hers luckily came back less than 10, which I feel like, given all the other cardiometabolic risk factors she has going on, she needed this to come back normal.
And we celebrated the moment, right?
Yes, the little ones. And then you see here at the 9-month mark, I mean, we were doing so good, and then we kind of went back to right where we started, if not worse. So here in between the second and the third visit, the patient actually ended up developing diabetes. And her weight did also worsen, as well as her BMI, and the triglycerides kind of went back up higher than that baseline level we saw.
Can you tell us more about her eating disorder that I assume was responsible for this backtracking?
So one of the main things that the patient reported, she was started on a new medication in between the second and the third visit. She was started on the depot shot. In addition, she reported poor compliance with her metformin during this time, and she stopped following that carb limit and kind of went back to those baseline dietary characteristics we saw. So, which is hard, especially with the pediatric patients. They do really well that first visit after, but it's really hard to keep the momentum going and really try to encourage them to follow the recommendations she set that first visit.
But in terms of the eating disorder that you mentioned, what kind of eating disorder?
Oh, she did not have the eating disorder. Oh, I'm sorry. I said emotional. She was having a lot of emotional eating.
Oh, emotional eating.
Yes, ma'am.
Which means what?
She was eating a lot in response to like her anxiety and maybe some undiagnosed depression, like using food as comfort. Not diagnosed, but just reported in the.
And why was she anxious?
I mean, like Dr. Wilson said, I mean, given, kind of the differences in her and the other, girls in her grade, that likely was causing some anxiety. I believe during the visit, there was some like maybe possible separation between mom and dad. I think that all was playing a role.
Okay.
So we'd love to get to, I think, one of the important questions is treating maybe diabetes, in this age group. You can go to your next slide, Maya, because I think it differs a little bit from all the options that the adult providers have. So I'll let you go through this, but then maybe we can discuss a little bit about, treating diabetes and how maybe what our options are for pediatric patients.
Yes, so at the third visit, and again, a reminder, that's when the patient was found to have diabetes type 2. Trulicity was added to her treatment regimen in addition to the metformin. She was kept on the same dose and re-educated on the importance of it. And then she did receive initial nutrition counseling for type 2 diabetes. So again, the carb counting again.
Yeah, so I just want to take a minute because often, you know, at least in the adult world, they have options like semaglutide, you know, which is Ozempic, even now Mounjaro, which is tirzepatide. And I didn't know if our panelists wanted to kind of comment on the options we have in the pediatric age group and you know, when you might even think about insulin in a patient like this.
Well, I mean, insulin is obviously indicated at some point if you have poor glycemic control, particularly an A1C greater than 8.5, whatever your number is. But I mean, clearly you want to avoid hyperosmolar coma, you want to avoid diabetic ketoacidosis. The problem is insulin is going to be counterproductive with regard to weight. And so if they're requiring a lot of injections for corrections or whatever, you're titrating the dose up, it's going to make it very difficult for them to stabilize or lose weight. The second thing is, with all this child's medications, compliance is a real issue. And so you could say, well, metformin was a failure here, but the reality is I'm not real confident she was actually taking it anyway, particularly if she's having any side effects or wasn't following the instructions as to how to take it properly. I think in general, maybe Amy, you could comment on this. You've had a lot more experience than the rest of us, but as a monotherapy, I don't think metformin is a great drug. I think it works in some patients and it's certainly worth trying. It's kind of standard therapy. But I think in pediatrics, we need to get more aggressive moving forward. Now that has been helped by development of the drugs that you just talked about. The next challenge though is getting it approved and paid for.
Yeah, so unfortunately, you know, there's only 2 GLP-1s, or actually 3 that are approved in the pediatric age group. One is the daily liraglutide, and then it's just exenatide and Trulicity. So often we're stuck with those as options. Semaglutide has been approved for pediatric patients with obesity, but not under the diabetes indication. And of course, tirzepatide has not been studied to date. So it's very difficult to get those medications. So we're often stuck with metformin and Trulicity as a second line agent if the A1C is not that high, and then insulin if the A1C is much higher. So yes, that's kind of where we're at. So I think we had another audience question that we wanted to take a poll on real quick and really ask, you know, there's a lot, as we mentioned, there's a lot of things that are going on with this patient, and there's a lot of therapies that are potentially going to be needed along the course. And for the audience, what therapy would be most beneficial for this patient to reduce cardiometabolic risk? Would it be metformin and OCPs, a GLP-1 receptor agonist, potentially a statin or an ACE inhibitor? Okay, and I'll ask our panelists if they have any thoughts on the audience response.
I agree with the audience. I think weight loss will correct the risk factors, cardiometabolic imbalance.
You know, I think early in this process, if all things were
If she's compliant.
Yeah, with all things considered equal, it would be ideal if you could actually try, like Wegovy, for example, to see how many of those risk factors you could actually either improve or knock out, with the proviso that you still have to do something, I think, probably to help ameliorate her facial hair, because that's kind of first and foremost for a lot of these girls. But I think if you believe that the weight is really driving the insulin resistance and inflammation, then we need to attack that pretty early. And
Would
the,
anybody start a statin? We had a question from the audience.
Not until you try weight loss. I mean,
yeah,
if
I don't think this early in the process we would. Even though the 2011 sort of said you need to consider this if it's persistent or severe, but I think it's a little bit early in the process. The other thing to think about is it for this child in particular, and for many of them, it's late in the ball game. But let's say in an ideal world we have safety data and efficacy on GLP-1s. What about when they just start really accelerating their weight gain early in the process, but before they get to the 95th plus percentile? Might we actually do a better job here? We don't have any data, but I'm just throwing that out there.
And then, okay, why don't we move on? And then I do want us to come back and talk about physical activity in the diet, since we do have some more, because we have Maya here as well. But Maya, we'll let you move on and get through some of these other things, talking points you wanted to share.
Yes, one of the next questions that the audience or the panel can discuss is that the presentation of her her insulin resistance to type 2 diabetes was started after her change of her medication from the oral pill to the depot shot. And from the literature, there's a lot of research supporting that there's an increased risk of type 2 diabetes development for women who are started on the depot shot compared to women on other oral contraceptives. Now, again, these studies are on adults, not children. But given the clinical findings in this patient's history, is there a preferred hormone replacement therapy you guys would have chosen as alternative?
Well, I mean, one of the things that's true about Depo-Provera is it actually is associated with weight gain. So again, you're kind of caught cross purposes. I mean, the American Academy of Pediatrics recommends some type of long-acting reversible contraceptive methods. But you have to think about, okay, are we trying to treat contraception? Are we trying to prevent irregular bleeding and so forth and so on? So these all have some kind of pros and cons. That's why these are lengthy discussions with your gynecology colleague. But I mean, a fair number of our girls actually would opt for an IUD.
yeah. I mean, I assume she was changed to the Depo-Provera because of compliance issues.
She was changed because she still wasn't able to achieve any menstrual bleeding. And I believe there was some concern in terms of like cervical cancer risks due to her not shedding her lining.
Yeah.
Okay.
Perfect. And then for this slide, this is just kind of a reference slide that discusses, again, that criteria that must be met to establish the diagnosis of metabolic syndrome. And like Dr. Wilson said earlier in the presentation, unfortunately, at this time, we don't have set guidelines for pediatric patients, but again, just looking for that cluster of risk factors that correlate to one of the ones that are typically used for adult patients. And then here's just a study. I want to really highlight the fact that our patients who have PCOS are at increased risk of not only developing metabolic syndrome, but also of developing type 2 diabetes. There is a recent publication done by the FNLA discussing cardiovascular risk and PCOS. And it was found that women who do have this condition have 9 times the risk of developing type 2 diabetes. And this risk increases by 3.85 times if they also are obese, in addition to the PCOS diagnosis. Even though we know PCOS is typically seen for women who are overweight or obese, there is a lean version. And here is just some recommendations for an international publication for the management of PCOS. And these recommendations are really related to the lifestyle treatment. Dr. Hudgins, you also talked about it earlier, but in this patient population, lifestyle should be one of the primary treatments discussed, and preferably with a registered dietitian. And this should always be a part of their care plan. And so we really want to make sure that we're providing like high quality, culturally appropriate education, and that these women understand the importance of not only a healthy diet, but also regular physical activity. And kind of going back to earlier where the patient's family had questions about the keto diet and if that is a good diet for PCOS. And the idea is that there's not necessarily one diet that's better than the other, but more so focusing on the individual components. Is this diet, allowing the patient to receive adequate nutrition, and is it high quality?
And can our panel just comment on the physical activity? Oh, I think you're going to it, but just on the physical activity guidelines for pediatric patients, because I think they are set by the American Academy of Pediatrics and are pretty much universally accepted across all diagnoses. So I think you have those there. But how feasible do you think this is for most children, and where do you start, I guess, when you have to make some recommendations?
Well,
Go ahead, Lisa.
they're it just I practice in New York City, and so most of the kids do not just open their door and go play for hours on end until the sun goes down. And so the only ones who are making the 60 minutes per day are those who are involved in sports teams, and so forth. And even there, it's not every day. And we have counteracting the physical activity, even something worse, and that's called social media. And it's driving the kids into just a total seclusion, it seems. So that's something that we have to fight with. And so I start with sleep, number one, because if they're tired during the day, they're not going to want to exercise. And then I do go over how much screen time and whether there are limits, and whether they prefer the baseball on the screen rather than real life baseball, etc. And I go through what they're getting in school, in their gym class, which unfortunately in some cases there is no gym in school. Maybe a little recess for the younger kids. It's a real issue. And then try to encourage, hear what they like to do, get them to brainstorm about what they actually enjoy, whether it's taking a walk, walking the dog.
Yeah. So start small and start with something accomplishable.
Yeah, you start small. You definitely don't say 60 minutes.
Yeah. And work from there up to a goal. So I did want to, I know we're getting close on time, and there was an audience question, and this is a group that is interested in lipids, and so they wanted some expansion from the panel on why perhaps you recommended holding off on the statin given the elevated non-HDL at this time, and the other cardiometabolic risk factors, and maybe commenting if it wasn't now, maybe, would you consider it even at a later point in time, or what would be your threshold in this patient?
Well, I mean, I think it depends upon the time sequence and how things are transpiring. So if things are getting better, you're getting some stabilization weight, the insulin resistance is reducing, you can be patient. The hypertension is not going to necessarily cause any immediate problems with the dyslipidemia, but I think as time goes by, we sort of introduced the concept that perhaps next visit, if your blood pressure is still high, we may talk a little bit about some medications to bring it down, or we may give you some medications to lower your cholesterol while you're working on these things, with the idea that hopefully we could work you out of that. So our goal would be to reduce your weight, get your insulin resistance under control, get your periods regulated, and then wean you down or off medications. But with the admonition that some people actually require medications to stay healthy as they get older. So that may or may not happen. Now, that being said, the other issue though is compliance. So you can put them on all these medications, but it's just like your geriatric patients. When you make it more complicated to keep track of the regimen. There's some cost involved, and then getting the kid to actually remember to take it. So if you lower blood pressure, you lower cholesterol, the child doesn't feel any different. They don't perceive any real benefit.
Maya, I'll let you continue and see if you wanted to hone in on any other key points as we're wrapping up on the discussion.
Yeah, just to kind of piggyback off where Dr. Hudgins left off, I know one thing that we really discuss with our kids when it comes to physical activity is kind of doing like these exercise bites of like 15 minutes of, some type of planned movement per day, and then kind of increasing those bites of 15 minutes to get them closer to that goal of 60. And for our kids who are doing weight loss, I heavily push the muscle and bone strength training because we don't want them to lose that lean body mass, and that any type of weight loss that puts them at risk of that. So it's really important. I talk with them about doing muscle strengthening exercises, whether it's using body weight or using some form of weight in addition. And physical activity is actually a mandatory part of the nutrition assessment done by a registered dietitian. And it's recommended that all patients diagnosed with diabetes meet with a dietitian at least once a year annually. And so for this,
I was just going to say, I think one of the best scenarios, if you can get the child to say, what would they be willing to do? And you asked the question about, well, what would keep you from doing that? How often would you start with that? What would happen if your muscles get sore? What if it's cold outside? All those potential barriers. When they say to me, oh, I'm going to join a gym, the answer is no, you're not. Feel free to join a gym, but that's not going to count for your exercise because A, you're not going to go. And you don't have, your family doesn't really have the resources to do that anyway. And the gym's located halfway across the town. So we try to kind of talk to them about realistic expectations. So sometimes we just have them get up and walk in place when there's a commercial on TV. And if you watch TV much, the commercials last forever. So, and then we try to reverse it where they're actually resting during the commercial. So you start off with small things and then try to build on success.
Yeah.
Sometimes,
Okay, Maya, 1 minute left. Any final thoughts?
yeah, so just for the last thing, really reiterating for our kids with type 2, carb counting is a big part of the nutrition assessment and the intervention. We typically would do carb counting with our kids, or the idea that they should be using this diabetic plate that you can see like in the bottom right-hand corner. With this plate, the idea is that half of it should be non-starchy vegetables. So we discussed the difference between the starchy and the non-starchy vegetable. All their carb food should fit on the quarter of the plate, and then protein should be a palm-sized amount, and preferably something lean, and that they should always pair their carbs, protein, and fiber for better glucose control. We discussed a lot about how sugary beverages should not be included in their diet anymore. And then family-centered approach and patient-centered approach are always at the foundation of our nutrition counseling, especially in this pediatric patient, because the kids are not the ones buying the groceries. A lot of times they're not the one cooking the meals. So we have to make sure the whole family is on board.
Well, and with that, what I think we've learned today is that these kids are complex. There's a lot of things going on, a lot of different things we need to be thinking about, and a lot of things to tackle. And I think importantly, we can't do it all at once, and it takes time and follow-up visits to tackle all of the components of the metabolic syndrome in pediatric patients.
That was well said, Dr. Shah, and you tied it up in 59 minutes, and this could have gone on for hours, and everybody's excited to hear from such an esteemed panel. I want to thank you for all participating, Maya, for your great presentation and case. The lipid panel meets last Tuesday of every month, except for those in the audience, November 19th, because we don't want to run into Thanksgiving. And we're going to discuss lipoprotein B, ApoB, how to use it, what it means. And we have Dr. Safa, who led the paper on ApoB for the FNLA. So please join us November 19th for our next lipid panel. And then we'll go back to our usual last Tuesday of the month. So thank you to our pediatric all-star team here. Look forward to hearing from you again in the future. Thank you, and thank you to our audience.
Thank you.
Bye.
Good night.
I
Bye.